Chapter 1, Overview of Antimicrobial Resistance. Introduction to Antimicrobial Resistance. Activity, Individual Reflection. Describe what is antimicrobial resistance is. Introduction to Antimicrobial Resistance. Antimicrobial resistance, or AMR, is the ability to microbes to grow in the presence of a class of drugs known as antimicrobials that would normally kill microbes or limit microbial growth. It occurs when microorganisms such as bacteria, virus, fungi, and parasites change in ways that render the medication used to cure the infections they cause ineffective. Some microbes are resistant to almost of all types of antimicrobials. When the microorganisms become resistant to most antimicrobials, they are often referred to as superbugs. Global and national magnitude of antimicrobial resistance. Activity, introductory questions. The magnitude of antimicrobial resistance is in developed countries is higher than developing countries. Is true or false? Discuss in groups. Burden continued. LMICs, vice versa, HICS. The problem more affects LMICs. This is attributable to AMR, 4.95 million diseases associated with AMR and 1.27 million diseases were directly attributable to AMR. Consequence of antimicrobial resistance. Activity 1.41. Per discussion and reflection. What are the consequences of antimicrobial resistance you faced in your setup? This is consequence continued. 1. Clinical consequence, economic consequence, social consequence. Not be careful. Despite the evidenced threat posed by antibiotic resistance, or ABR, information on its clinical, social, and economic impact is limited in developing countries, and thus impede appropriate interventions for its containment. Heightened awareness of policy makers, healthcare workers, and the general population about the risks associated with antibiotic resistance is essential to preserve antibiotics for future generations. Plenary session. Healthcare associated infections overview. Activity 1. Infection occurring in a patient during the process of care in a healthcare facility. Example, infection acquired in the hospital or appearing shortly after discharge. These are microorganisms, multi-drug resistance, virulence factors, host factors, old age, debilitation, immunosuppression, hospital setting, space, ventilation, cleanliness, procedure, diagnostics, therapy, care, rehabilitation. These are healthcare-associated infections. Risk factor and the nature of etiologies. The burden of HAIS. The burden of healthcare AIS is increasing. Prevalence in high-income countries is 7.6%, while 15.5% in LMICS. Estimated pooled prevalence in Ethiopia is 16.96%. The burden of HAIS, SCIS, IPC measures relevant to AMR prevention. Fight antibiotic resistance through the trinity of better infection prevention and hygiene, better antibiotic stewardship, and better surveillance. It is in your hand. When you wash hand in healthcare, personal protective equipment, integrating AMS with other hospital initiatives. These are clinical, pharmacy service, diagnostic team, patient safety team, drug and therapeutics committee, antibiotic stewardship, unique skill set and experience, infection prevention and control, collaborative team, collaborative goal and activity, shared vision, reduce the HAIS, prevent AMR, effective conflict management, strong joint leadership, readiness for change, committed team members, trust, common understanding, open communication, accountability, global response to AMR. Chapter 2, Antimicrobial Stewardship. Prospective audit and feedback. By the end of this chapter, the participants will be able to apply antimicrobial stewardship strategies, enabling objectives, understand and apply prospective audit and feedback to optimize antimicrobial use, understand and apply the restrictive interventions to optimize antimicrobial use. Prospective audit and feedback. Definition of auditing. Planned review of patient history. Prospective. Optimization of therapy by interactive discussion with prescribing physician or persuasive. Key activities required for PAF. Identify patient settings interventions for PAF. Assigning auditors. Auditing, covering pertinent data, generating intervention or recommendations, providing feedback, document and follow-up. The auditing tool. You may need to adapt or adopt the Ministry of Health auditing tool. Display and discuss the audit tool here. Reviewing patient data, antibiotic data and the response. Further issues will be addressed under auditing tool. Audit finding and the AMS decision. Assessment or recommendation, suggestion for decision or discussion. Sufficient data available to recommend the following: stop, modify, add or change, IV to PO, switch, continue, dose optimization, outpatient parenteral antibiotic therapy or OPAT. No suffice data or the condition do not allow for a decision. Work up required review on day, example on the next 1 to 2 days. How should feedback be provided? Consideration to communicate feedback based on urgency or point of care intervention, vice versa, waiting for AMS rounds, and based on complexity of the case, vice versa, consult ID specialist for approval. How to communicate feedback in person or very rarely through phone must be avoided for routine use. To the prescriber, documenting feedback in patient records and the following it is consideration presented to regular AMS round led by senior clinician in the presence of a prescriber team. Risk or costs pre-requests for PAF resource and time-intensive support of leadership, facilitations, team commitments, requires a method for identifying target patient population, requires clinical expertise and excellent communication skill, communication with frontline staff, acceptability, preferred way of implementation, allow for adherence to recommendation, to often remain voluntary. Restrictive measures. Restrictive intervention have been shown to provide quick positive results in reducing antibiotic use. However, after around 6 months, restrictive and persuasive interventions are equally effective. Readers are recommended to check the WHO AMS guideline for low and middle income countries. WHO 2019. Formulary restriction and pre-authorization. Antibiotics are restricted before use. That prohibits prescription of certain antibiotics for certain contexts or require mandatory approval to continue the empiric prescription. Commonly implemented to restrict the last resort antimicrobials. The approving person skill and the real-time availability is important. This restriction may shift rational use of alternative antimicrobials unless monitored.